It's about 8:03 a.m. Eastern Time and want to get started on the breast portion of the Osler review course. My name is Peter Wu. I'm a attending at City of Hope. I have a special interest in breast cancer. I know the exam is coming up very soon, May 14th, and the week of May 19th for the oral boards. A lot of the breast cancer literature may not show up on the oral boards, so I'll focus more clinically on the literature aspect and really spend a lot more time on the clinical aspects, which I think will be quite valuable. There have been some significant changes over the last even 2 or 3 years, and I hope this presentation will allow you to broaden your current horizons as well as reinforce some foundations that you've had previously. Um, this is the general flow of the presentation. Anatomically, the breast is connected to several lymph node chains, them that you know quite well at this point. There are the internal mammary nodes, the axillary lymph nodes, which are separated into three echelons: axillary level 1, 2, 3, and as a continuation of perhaps both, it's the supraclavicular lymph nodes above. There's also intramammary lymph nodes and lymphatic channels that span from the breast and nipple and areolar complex. The breast itself is separated into different quadrants. The most common quadrant for malignancies is the upper outer quadrant. The left breast and the right breast you can imagine seeing them as an examiner, not as the patient. So the right side is on the left side of the screen, and the left side is on the right side of the screen. This is the convention for not only the positions and codes of the quadrants of the breast, but also mammograms. Breast, notably also, is sitting behind several bony structures. It's behind the sternum, as well as the clavicular heads, as well as the chest wall, which lies beneath. And these serve as important 3D structures, landmarks, I should say, when contouring, even in this CT-based era. There's several updates to breast cancer since AJCC 8. It's probably well familiar to you at this point, so I'll gloss over this. But this is incredibly important for breast cancer. The staging system, both prognostic as well as um, the anatomic staging, remains a cornerstone of how we communicate about breast cancer, because truly there is biological differences between a small tumor, a T1 or T2 tumor, and a larger tumor, T3, or an inflammatory tumor, T4D. I think it's important to know the cutoffs between T1, T2, T3, T4, and also the special categories of T4, most importantly, inflammatory. We'll get into that in the next presentation. Less important, I think, is knowing the exact staging through the new prognostic stages that implicate ER-PR positive or other biomarkers, bioreceptors, I should say. It's really impossible to memorize all of these categories. It's more of a feel, but generally, I think it's important to know that these are part of the prognostic stages and oncotype scores as well. And so all these put together, we have some important changes to T staging that are summarized here, and changes to N staging that are summarized here. We could go into the nitty-gritty details, but I don't think it's a great use of time. Now, let's talk about breast cancer from a 10,000-foot field of view, taking the forest for the trees. Every year, there's about 200,000 new cases of invasive breast cancer diagnosed in the United States. 50% of breast cancer is stage 1, early stage. Most breast cancer is luminal. There's two categories, luminal A and luminal B, both of which have better prognoses than basal-like or other less good prognostic triple negative HER2 positive, ERPR negative tumors. About 20% are HER2 positive, and about 10% are triple negative. So that's a nice number to remember. 75, 20, and then maybe 5, or 75, 15, and 10. Depends on how you where you practice. Breast conserving therapy for invasive breast cancer comes from a long line of work by Bernard Fisher and his NSABP group. There's some landmark studies, most importantly NSABP B06, in which breast cancers who underwent lumpectomy were randomized to radiotherapy or no radiotherapy. And these were stage 2 or stage 1 breast cancers. And as we see, the patients receiving lumpectomy, the triangles here have a better overall disease-free survival than those who do not. And this was the genesis of all of the various literature that we are well aware of at this point. As you also see, the actual p-value was not significant for disease-free survival. So that's also interesting. But I believe there were some important local control benefits that was established. At that point, this established BCS as equivalent to mastectomy, and several other styles, including B06, found similar outcomes, that lumpectomy plus radiation is equivalent to mastectomy when it comes to disease-free survival. There's no significance between any of these trials, and something you can use to guide your discussions with patients, the approximate equivalence of these two procedures. The EBC-TCG, the Early Breast Trialist Collaborative Group, put together a meta-analysis of several randomized controlled trials. And within these meta-analyses, they found not only a local control benefit, but also a overall survival benefit when whole breast was combined on top of lumpectomy, meaning at the addition of whole breast or radiation to lumpectomy contained a survival advantage for patients over lumpectomy alone. That's an important contribution of this meta-analysis. And so we also counsel women that those with node-positive disease seem to benefit even more than those with node-negative disease. The overall survival benefit clearly separates here with a p-value that is significant, log-rank p of 0.01, whereas the absolute separation is smaller. However, the p-value is even lower for the lumpectomy patients because there are more patients in this group. These are trends that are seen later in the literature in the decades to come. I've rearranged this presentation a little bit. I think the most important topic we should start with is hypofractionated whole breast irradiation. We'll jump right into the techniques because it's important to know about the trend in our field of breast radiation oncology, which is an increase in hypofractionation as well as increase in partial breast therapy. Less is more currently in breast radiation. It really brings patients equivalent outcomes with much better time savings, financial toxicity, as well as some might argue quality of life when it comes to cosmesis in some cases. So moving forward, hypofractionated whole breast irradiation, maybe whole breast or partial breast. There are schedules that include 40 gray and 15 fractions to start B, or 42, 56 gray and 16 fractions, also known as the Canadian Timothy Whelan fractionation. They vary from 2.66 to 2.67 gray per fraction, but approximately in that range. And we already spoke about the pros of these treatment strategies. So hypofractionated radiation delivered over 3 weeks finds its genesis in several trials even before START A, but these are probably the most well-known randomized trials. START A looked at a different regimen. It was 41.6 gray in 13 fractions and compared it to 50 gray in 25 fractions. And patients here were, again, early stage. They were sometimes even node positive, which forms the basis of, again, regional nodal radiation using hypofractionated regimens. Many had chemotherapy, and the outcomes demonstrated a local regional recurrence rate of 7.4 for 50 gray, which is what we usually do, and 6.3 numerically less at 41.6 gray in 13 fractions. Statistically, there was no difference in any of the three regimens. I'm not focusing on this one because it's not done often. But there was less edema with 39 gray than 50 gray. And there was also less induration with the lower dose. Well, there was no difference in cosmetic outcomes between these two regimens. So same outcome, better side effects. START B, more often adopted here in North America, involves a hypofractionated regimen of 40 gray and 15 fractions at 2.67 gray in 3 weeks, and a standard fractionation comparator arm. Again, we see numerically higher recurrence rates in the 50 gray arm versus the 40 gray arm, and there is reduced breast shrinkage, telangiectasia, and edema in 40 gray. Better outcomes, maybe numerically or statistically, no different outcomes, and improved side effects. This was also adopted here in North America because there's the option to add a 1 week boost onto this fractionation, and it became quite a favored regimen. There's the Ontario group, the Whelan fractionation, which provided an alternative regimen, but also a verification of the previous two findings. They used 42.56 gray in 16 fractions. And as you see, the hypofractionated regimen again had a lower, about the same, I should say, 10-year recurrence rate as standard 50 gray in 25 fractions. And they again found very similar toxicities, ranging from, slightly higher for grade 3 tissue toxicity to slightly better for cosmesis, but these are all statistically indistinguishable from one another. And thus, as a summary of several phase 3 studies, I think this calls this the Ontario Clinical Oncology of Interesting, OCOG. It's important to note that many of these women were premenopausal, many of these women received chemotherapy, many of them even had node-positive disease. And so hypofractionation was poised and is poised to be suitable for nearly every woman of any age category, of any risk category, of any stage category. And we're moving towards that right now. The ASTRO consensus statement in 2018 for whole breast reflects this. Any age, any stage with any chemotherapy, and there is a dose homogeneity guideline, which is truly good practice, even for if you're using 50 gray in 25 fractions. Try and keep the volume greater than 105% minimized, regardless of dose fractionation. But it becomes even more important when hypofractionating, because that would mean, say you have a hotspot of 120. I hope not, but then that is closer to, 3 gray per day, which is very different than 2.66 gray per day. There are different ways of delivering hyperfractionated whole breast radiation. They can include low tangents, which means being within 2 centimeters or 1 centimeter of the inferior border of the humeral head. It depends on how you define it. Or covering the majority of level ones and level two lymph nodes, not reaching into the majority of level three, and certainly not reaching the supraclav. There's they can also indeed even now, and you'll see it in the NCCN guidelines, this can also be done in a regional nodal radiation aspect. I apologize, this slide looks like it doesn't include that. As long as there's no reconstruction. And I made sure to add here, there are ongoing trials investigating the effect of hyperfractionated radiation on reconstructed chest walls. And that's the Alliance trial, RT-CHARM. So hypofractionated whole breast radiation is already prime time, and one should consider it for many patients, even those with collagen vascular disease who are not having active disease. Oftentimes, actually, it's a bad idea to treat anybody with collagen vascular disease with any sort of regimen if they're having active disease. It's better to have it under control first. And breast cancer is one which, a month or two delay may still be clinically valuable to give radiation. Let's talk about what has been happening over the last 5 years, which is
Dr. Wu,
yes.
a question just came in, I believe, about one of the two previous slides.
Yes.
It says even if they get concurrent chemotherapy.
No, that's a great question. Breast radiation is not given with concurrent chemotherapy unless it is a non-surgical case or a palliative case. Sometimes we make exceptions. Chemotherapy is given either neoadjuvantly prior to radiation, or radiation is delivered usually after chemotherapy. If a woman has a high oncotype score with an early stage breast cancer, for example, they will get chemotherapy first, and following chemotherapy with usually a washout of about 4 weeks, one gives breast radiation. Thanks for the question. We'll move on. That's great what you did, John. Please shout them out. I can't see the questions, unfortunately.
Okay.
Please, yes. So moving forward, UK fast forward over the last 5 years represents one of two intriguing ultra hypofractionated breast regimens. This terminology, I believe, was borrowed from prostate cancer, which 5-fraction prostate cancer is also called ultra hypofractionated. These included early stage breast cancer patients, again with N0 and N1, very reminiscent of START A. And they were randomly assigned to have 5 fractions in 26 gray and 5 fractions, 27 gray and 5 fractions, or 40 gray and 15 fractions. The justification for this is the low alpha beta ratio of breast and perhaps improvements in tumor control with a decrease in decrease in normal tissue toxicity with higher fractionation per day. What was found was very interesting. These curves appear to not separate when it comes to ipsilateral breast cancer recurrence, IBTR. So there seems to be equivalency when it comes to effectiveness. However, when we look closely at this apologize, this is a different study. There is a difference in cosmesis. It's not listed here, but there was poorer cosmesis with the ultra hypofractionated regimens. Here's another way of delivering ultra hypofractionated radiation. It's a separate trial. It's called UK FAST, not Fast Forward. This is a good regimen to use on perhaps the woman who is in a wheelchair, may have had a stroke, and may not be very functional, but still has a very important breast cancer risk profile that it's worthwhile to treat. The regimen here that was tested was 30 gray in 5 weeks, so 1 fraction per week, or 28.5 gray in 5 weeks, 1 fraction per week. And again, very similar results. There seems to be here on the bottom, the worst cosmetic outcome when giving 30 gray in 5 fractions, but similar cosmetic outcomes when giving 28.5, but maybe numerically worse outcomes in the dark blue line, which represents 28.5, and very good at cosmetic outcomes or superior cosmetic outcomes with 50 gray. So all in all, I think it's important to keep these in mind. This is likely worse cosmetically. However, it does provide a valuable option for patients with high comorbidity, low life expectancy, but still risky breast cancers that deserve some sort of radiation. Let's move forward. Oh gosh, the slides, they're going the wrong direction. All right. So when it comes to patterns of care for hypofractionated breast radiation, Beckelman at UPenn showed a utilization of hypofrac in the United States to be only 34% in 2013. And we're doing much better lately. I believe it's over 50% now, but it's certainly a far cry from the 2018 Astro guidelines and NCCN guidelines too, which have said that this is okay for all patients. The lag is likely multifactorial, but don't be shy during the oral boards. It's okay to say hypofrac for nearly any case, except perhaps in those who have been reconstructed, as we are still building the evidence base for that. Let's move on to partial breast irradiation. Partial breast irradiation is also a well-tested type of radiation at this point, with every single modality having more than 10 years of follow-up in a randomized phase 3 trial. There are various types of partial breast radiation. Okay, this slide is a little out of date. Interstitial brachytherapy, intracavitary brachytherapy, which is done with one of a single lumen or multi-lumen catheter. Intraoperative radiation, which is done with electrons or photons, usually KV photons, not MV photons we're used to, and 3D CRT, or IMRT/VMAT, which is my preferred way of doing partial breast radiation with external beam. There's an image from Kahn in 2006 with the concept. Really stems from the great work Silvia Fomenti did, as well as many people in Italy, to bring this to fore. As well as many other early physicists and biologists who took the leap in the early 2000s. Here are a collection of APBI trials. This is not at all comprehensive, but it's important to know. I'll point out a few salient ones throughout this presentation. Import low is a very unique one in that this partial breast is not accelerated. It's not accelerated APBI. This is misspelled. It should be APBI. Apologies. Many of these slides are legacy slides. This is just PBI, which is partial breast irradiation. It uses a hypofractionated regimen, but treats part of the breast. We also have a lot of experience here in America, not from UK, not from Italy, with the RTG 0319 study, which used a BID regimen. Anyways, moving on. Partial breast techniques, again, are based on the scientific insight that most recurrences occur within a close proximity to the tumor bed, approximately 1 centimeter lumpectomy cavity, about the lumpectomy cavity. Thus, these various modalities were suggested. Accelerated partial breast radiation can be done with IORT. I would shy away from saying IORT on the oral boards. I'm just really telling you about this as an FYI, maybe a historical artifact. The IORT is supported by 2 papers called Target and Elliott. It can be done with a balloon. I believe the company is called Mammocyte or Contura, essentially you put a balloon into the lumpectomy cavity, you fill it with saline, and there are various catheters you can hook up. Apologies. What am I saying? I'm talking about brachytherapy. IORT is done with within the operating room using special machines that are outfitted with electron or photon heads. Um, and it can be done with the image guidance as well. Um, Interstitial brachytherapy is done with catheters that are inserted directly into the skin. And this is perhaps the first and most original way of doing a brachytherapy for partial breast. This is another type of brachytherapy for partial breast, which is what I was speaking about earlier. Need more coffee this morning, I apologize. And essentially, this used to be quite a popular route of doing partial breast. Me and some colleagues are writing a review of the uh, changes in practice of care. This used to be the dominant form of partial breast. Now external beam is becoming dominant. Again, there could be single lumen or multi-lumen catheters. You can contour or more of the dose distribution with multi-lumen catheters. But you can still get a very respectable dose distribution with single lumen catheters. External beam partial breast radiation involves oftentimes non-coplanar beams if you're using 3D CRT, which means the couch is kicked, gantry is rotated, and a non-coplanar entrance beam is delivered for maximal conformality, but also as a side effect, you get better skin sparing with this. Um, there is a experience with IMRT using by the University of Florence, Miatini et al. And Levy et al., which is 30 gray in 5 fractions, which is a very effective regimen. And they've had really excellent cosmetic outcomes. And I use this quite often, and there are other regimens as well. Protons are a question mark, and MR guided partial breast are a question mark. Already we're getting excellent cosmetic outcomes using 3D as well as IMRT based partial breast. So it remains to be seen whether there is truly much benefit using these modalities. Um, I would doubt it, especially in patients who can go prone. Um, this is one of the earliest partial breast irradiation trials. Again, it was conducted in Hungary with interstitial brachytherapy compared to whole breast radiotherapy with external beam radiation. There are no differences at 10 years noted when local failure for these T1 N0 to N1 mic patients, grade 1, grade 2, invasive, non-lobular negative margins. It's important to note, I think the most important thing from this is not the technique or the dose, but it's important to note non-lobular patients were included. Lobular patients are even at this point cautionary or not as suitable for partial breast radiation, given the the radiographically difficult to localize nature of lobular and also the unusual distribution of lobular. I've seen lobular cancers have absolutely no axillary findings, but then on dissection, 16 nodes being positive or something unusual like that. So lobular is definitely a very tricky histology to work with, and you may not be able to trust your imaging findings as well. Um, uh, Many people had excellent or good cosmesis, better than that of whole breast radiation. So this addressed two of the main questions. Is it as good? And also, is there better cosmesis? And yes, on both fronts. Um, the GEC-ESTRA trial continued this on a larger scale in many different countries in Europe, compared partial breast radiation with, again, interstitial brachytherapy and external beam radiation. And they had their own criteria, which are still very good criteria even to this day. 40 years or older, um, perhaps 45 years is what Astra would say, but PTIS um, or PT1A to 2A, less than 3 centimeters, N0 to N1 mic, negative margins, 2 millimeters for invasive, 5 millimeters for DCIS. Here is a retrospective study which looks at the Mammocyte registry and very similar results. Again, similar low local recurrence in this well-chosen patient population emphasis and very good cosmesis higher than historical rates for external beam. This is jumping around a little bit. Um, Moving on to external beam partial breasts, this is a technique that can deliver similar outcomes with a widely available technology, our linear accelerators. Um, uh, from experience, this is also much easier than doing IORT and brachytherapy-based regimens, just because the patients don't have to have any, catheters removed, and it is also non-invasive, and further, it can be just as fast, if not faster, than brachytherapy-based and IORT regimens. Maybe not faster than IORT, but for Menti et al., one of my mentors pioneered a 30 gray and 5 fraction every other day prone partial breast radiation. Tagian looked at 2 mini tangents on FOSS, 30 to 40 gray, 8 to 10 fractions BID. And Vivini looked at 4-field supine, 38.5 gray and 10 fractions. Again, these were non-coplanar fields. One from this angle, one from this angle, one from this angle, one from this angle, not in the same plane as we usually see. And each of these had very similar results, and these are different techniques that one can do this by. VMAT can also be used, IMRT can also be used. Truly, the cosmetic outcomes are just better because you're treating less of the breast. Here is the University of Florence trial that looked at patients who were 40 years or older, tumor less than 2.5 centimeters, margins greater than or equal to 5 millimeters. The two arms were 50 gray in 25 fractions versus 30 gray in 5 fractions. This was delivered with VMAT, and clips were placed at the borders. There were a minimum of 4 clips. A 1 centimeter CTV was placed upon the GTV, which was not GTV, the clips themselves, and the tumor had been removed by surgery, and 1 centimeter expansion on top of the CTV for the PTV. CT was cropped from the skin surface, and certainly you can crop it from the chest wall and the lungs as well. This is very, very similar to what I do today, and here we have the local control IBTR curves. They do not separate. They're very similar, and the cosmesis was greater than 90%, good and excellent. I think it was actually even 100% patient rated cosmesis. I haven't seen that very often in your academic journals, but I think it was 100%. The double check me. So that's an excellent way of performing partial breast that's available to all of us. This is also made sure to mention the CTV and PTV expansions if you do happen to come across a suitable candidate on your oral boards. Those are excellent ways of performing the CTV and PTV expansions. The toxicity, again, was quite low. Here is another way of doing it. It's the UK import low. I think many people shy away from this regimen because if you're going to give partial breast, why not do it even faster than 15 fractions? Why not just do the Florence experience, 30 gray and 5 fractions? But this is another way of doing it. Instead of treating the whole breast, you just treat with mini tangents, 36 gray or 40 gray with mini tangents, lowering the top or raising the inferior border of the tangent fields to treat a smaller portion of the breast. Here is yet another way of doing it. It's a rapid trial. It compares 38.5 gray in 10 fractions BID with whole breast 4256 hypofractionated regimens. So this is an important trial, not for the dose regimen, which is again more inconvenient, but rather comparing it with a hypofractionated regimen. We think the conventional hypofractionated are equivalent from the trials I presented previously, but this is a direct comparison. And again, there is still lower toxicity acutely in APBI, but they found a higher late toxicity in APBI, and this cautioned people from using APBI probably for the wrong reasons. But I think the caution should not be the technique itself, but rather the dosing. Perhaps this is too high of a dose to be done. Moving on, NSABP B39 is another experience with partial breast. Um, in this trial, APBI was delivered via HDR or external beam as chosen by a radiation oncologist. Again, external beam was 38.5 and 10 fractions. HDR was 34 gray with either mammocyte or interstitial. And again, the 10-year difference in IBTR, and ipsilateral breast recurrence rate was 4.6% versus 3.9%, approximately 1.3% difference. Sorry, less than one, less than 1% difference. But because of how this was designed, there was a thought that these numbers represented a worse outcome than whole breast. But there's no difference in overall survival, no difference in distant mets, and truly look at these numbers for yourself. Is this truly a very different outcome? I'm not so sure. So the conclusion was APPI versus via EBRT or HDR was inferior to whole breast with regards to ipsilateral breast recurrence, but still very, very low, with absolute increase of 0.7% or 0.017% at each year, with similar rates of treatment-related toxicity. Again, I think this is probably accurate because you're not treating the whole breast. There is a higher rate of recurrence in the untreated breast, but given the oftentimes low risk population that's chosen, it's still the right thing to do for many, many patients. So in 2023, given the maturation of many of these trials to their 10-year endpoints, is another update produced by many really great breast radiation oncologists. I think authored by Shadelman et al., but two of my mentors around there, Jose Bazan as well as Namit Gerber, demonstrate a very large population of patients who will be suitable for partial breast radiation. It's recommended for patients with early stage invasive breast cancers who have, and this is important, I'm going to slow down, so please really pay attention, grade 1 to 2 disease, ER-PR positive, sorry, ER positive histology, not necessarily PR positive. Luminal Bs are okay. Age 40 or over. Some would say 45, but 40 or over. And tumor size less than or equal to 2 centimeters. The quality of evidence is very high for patients aged greater than 50, and it's moderate for patients ages 40 to 49. But the group has stated as a whole that it's okay. Over 40, it's okay. So this was a big controversy. Um, so these are suitable patients, absolutely suitable for partial breast. All the experts agreed that this is totally fine given the maturity of the data that we looked at. It is not recommended, this is also very important, not recommended for patients with HER2 positive tumors not receiving HER2 therapy, lymphovascular invasion, or lobular histology. As we highlighted early on, lobular histology is an important, conditional, not recommended. Further, it's not recommended for patients with positive lymph nodes, although some of the trials had micrometastatic lymph nodes. I think this suggests regional spread, which is not an indication for a smaller treatment, but a larger treatment. Positive surgical margins, known germline BRCA1/2 mutations. This is very important. It wasn't put out front in the previous guidelines. It was in the the longer supplementary material, but now it's put up front and age less than 40 years. So if a young woman has not been tested for BRCA, make sure to test her before giving partial breast. And everyone in between that do not fall into these categories in a very inclusive way can be considered conditionally recommended, and a lot of discussion has to occur. I think in this era, most patients do not get partial breast if they have ER negative cancer, grade 3 disease. or if they have a size that's less than 3 centimeters but greater than 2 centimeters. Um, it's oftentimes still better to do whole breast for these patients. So err towards that when you get it on the oral boards. Um, okay to recommend partial breast for these patients. Do not recommend partial breast for these patients. All right. These are the ABS guidelines. Many of our practitioners that trained us, and many of us will become brachytherapy practitioners too. This is qualitatively a very different modality than external beam. The isodose lines are very different, and so perhaps there should be different criteria for these patients. Age greater than 45, less than 3 centimeters. Um, Again, no LVI, and the histology is okay to do lobular apparently with brachy from the previous experience, but still have caution with regards to the lobular histologies in my opinion. Um, and this is also a nice set of guidelines to know. So IORT, I just want to make one note before moving on to the next topic. IORT is becoming less and less popular given the long-term follow-up of the Elliott and Target trials. Here you see in the Target investigators, this is using electron-based intraoperative radiotherapy. The local recurrence is increasing at 5 years, separating from external beam radiation. It's significant, and it's important to note that may not be equivalent as the other APBI techniques are, even in a well-selected population. And here is the IBTR rate from, I believe this is the same trial. No, I think this may be from Elliott. I think this may be from Elliott, which is another trial. So in any case, oh gosh. The local recurrence curves continue to separate in both trials. And so Astro in 2016 came out with important guidelines answering the question, which patients are considered okay for intraoperative PBI? Number one, they must be suitable, very much so, for partial breast radiation. Don't do this in conditionally suitable patients, or certainly not unsuitable patients. And the electron beam IORT should be restricted to patients who are suitable, and the low energy X-ray IORT should really be used in the context of a study. You really have to think about why you're doing this, and if there's any ways of improving that type of therapy. And so moving on, it may be in your best interest not to mention IORT on the oral boards. It may put you down a rabbit hole. So shy away from that. Omission. This is a topic I'll speed through as we're running low on time. But can radiation be omitted? There's an increasing literature that in certain populations, radiation can be omitted. It starts from looking at the local recurrence rates in the modern era being much lower in omission trials. For example, the famous CalGB 9343, which looked at low-risk patients who had tamoxifen therapy instead of or tamoxifen and radiation, found a 7% versus 1% recurrence rate in those with radiation at 5 years follow-up. At 10 years follow-up, these trends continued. And so even though this is a higher number, it was not found to be different in overall survival. So again, we'll just speed through these.
Dr. Wu,
Yes.
a question came in a slide or so ago. It says, does the ASTRO guidelines suggest dose and fraction for early stage PBI?
The Astro guidelines,
Yes.
not yes. They do. There are lots and lots of recommendations for doses you should use. They do not suggest one dose. I would suggest you look at it. They suggest different doses for brachytherapy based, interstitial based, as well as external beam based radiation. Many of them are inclusive of what I presented here. They also omit certain doses too that I presented here, and I'd ask you to take a look at the guidelines. All right, we must accelerate. We have quite a few slides left. So NSABP B21 was one of the earliest trials looking at emission of radiation. There's three arms: tamoxifen radiotherapy, or RT plus TAM. As you can see, the RT plus TAM arm had the best outcome with 2.8 recurrence rate at approximately 8 years, whereas no radiation, just tamoxifen alone had the highest recurrence rate, 16.5%, and the XRT plus lumpectomy had a recurrence rate of 9.3. Though this was done decades ago, these numbers are very stable. It's approximately, a 10% at most difference in IBTR with radiation. Prime 2, I think these trials are more modern. It's important to note the inclusion criteria for these trials because they represent the candidates that might be omitted should they absolutely want to omit radiation. Although there is a measurable benefit in local control, these women included in Prime 2 were age 65 or older, T1 to T2, less than 3 centimeters, negative margins, ER positive, N0, grade 3, or, excuse me, this is a little not well stated. ER positive, N0, they could have grade 3 or LVSI, but not both. That was not allowed. So that those patients received either endocrine therapy alone or endocrine therapy with radiation. And again, we see a small but probably clinically not as important separation in the curves when it comes to IBTR. And this did not represent any difference in overall survival. The IBTR rate was 3.2%. Sorry, 1.3% versus 4.1% at 5 years. Most importantly, no difference in overall survival. Oncology B9343 looked at an older population, 5 years older, age 70 or greater, T1N0 ER positive with tamoxifen plus or minus radiation. Again, you see a separation in the curves at approximately 15 years follow-up. There was a local control recurrence difference of 10% versus 2%, approximately a 8 to 10% difference if you omit radiation. Again, no difference in overall survival whatsoever, none. And the BASO 2 trial, very similar results as well. It was 8% versus 2% at 10 years. The ABCSG trial, also very similar results. It was 0.4% versus 5.1% at 5 years. And then for some reason at year 6, they're almost double the number of recurrences. 0.4% versus 9%. This is probably an artifact of the trial rather than anything else. It's important to note that there's one axillary recurrence in the no RT arm and 0 in the RT arm. So most of the recurrences were local within the breast. Here's a small plot that one of my predecessors put together, which I think was very nice. Just noting that all these trials kind of fall on the same line. RT plus TAM has or RT plus hormonal therapy has a very slow sloping curve, whereas TAM and AI alone have a very high sloping curve, approximately 1% per year for this curve, and approximately, what is 0.2% per year with this curve. The next generation of omission trials have begun. This one is run by Dr. Jagsy, formerly at Michigan. I believe she's now chairman at Emory. There is an idea of incorporating younger breast cancer patients with age 50 to 69 with low oncotype scores. Pardon me. Those with risk scores less than 11. Excuse me, not less than 11, with a mean risk score of 11 and generally low risk by oncotype, and also better imaging, MRI, for radiographic staging. And this was presented at San Antonio last year, the most recent San Antonio breast conference. And again, early results demonstrate really very similar outcomes for these two groups if they're well selected. Excuse me, this is a non-randomized trial. This is a single group trial, but look at the difference between women who were traditionally thought as candidates for admission. Actually, this is still a little too young, 65 or older, I should say, versus those that were not traditionally thought to be candidates, but biologically selected. The curves are very similar between these two groups. There's numerous trials. To follow up on the IDEA trial, there's the Deborah trial that numerous trials that are being run right now. The Deborah trial is a randomized trial rather than a single arm trial that seeks to reduce radiation or emit radiation in patients with a by oncotype score, those with the oncotype less than 18. And there are many other ones. I'd encourage you to look into them on your own. And we'll move on. Some of them incorporate APBI rather than whole breast radiation too. In regards to boost, which patients should we boost? Many women seem to have high risk or higher risk tumors based upon their histology, ERPR negative status, or perhaps they have close margins or positive margins. These women, when it comes to radiation, may benefit from a boost. The most famous boost trial, the ERTC boost trial 22881, looked at boost in after whole breast in over 5,000 women. The 10-year ipsilateral breast recurrence rates were improved with a boost by approximately 4%, but among subsets, there was an even greater improvement in women who are less than 40. Notice it was there was almost a 34% recurrence rate in patients who did not get a boost at about 20 years in women who were under the age of 40, which was reduced, quite a lot, to 20% if they did receive a boost. And this effect seemed to diminish with age to a point at 60 in which it was no longer significant. I take that back. It was still significant, but still, as you can see, the curves are really getting quite close. And so this is an important principle to bring to your clinical practice, and it's reflected in our ASTRO guidelines. Boost is recommended for those who are younger, who may have a higher risk of breast recurrence, both biologically and also just by the virtue of age. And it can likely be omitted in women who are over 70, who have limited lifespans, and also oftentimes less aggressive breast cancers biologically. Another trial was conducted in France, the Lyon trial, and the whole breast radiation was augmented by 10 gray boost. Very similar results. There was a marginal improvement in ipsilateral breast recurrence, and also a worsening of telangiectasia, as you might imagine with more radiation. Here are all of the various boost trials: the ERTC, Budapest from Hungary, Lyon trial, and the Nielsen study. Each of which looked at boosts in various populations. A nice takeaway that we didn't mention earlier is that there's, even for patients with positive or close margins, high mitotic count, and young age, the boost did add extra benefit and actually added greatest benefit. So these are nice populations to consider boosting. What about a higher boost dose? Please rate your agreement whether you would consider 10 gray versus 16 gray for these patients. 16 gray is done now usually for patients with positive margins. Definitely, yes, 50% of the people. Or maybe with close margins. It's rarely done otherwise. 10 gray is the more standard dose. So just be aware of that. In ASTRO 2018, the whole breast guidelines have recommended omission of boost in patients who are 70 or older with negative margins greater than 2 millimeters with invasive disease, and recommended boost with patients who are less than 50 years old with high-grade disease if they are 50 to 70, or if they have obviously surgical margins positive. For DCIS, this is a different study that we'll discuss later. Here are the NCCN guidelines. These are really important guidelines to follow because they are really well encompassing of what everything we discussed, and I'm glad we're ending here right on time. Um, there is a consideration of APBI in select patients who are low risk. Category 1 recommendation. Consider omitting breast radiation if they fall into these categories, as we discussed earlier, prime 2, as well as CalGB 9343 criteria. Category 1, again, or of course the old trusty regimen of whole breast plus or minus boost, and we talked about the nuances of that just now for any patient who does not fall into either of these categories. For those with positive lymph nodes, we'll get into that in the next presentation discussing locally advanced breast cancer. There's 2 minutes left. I have more slides, but they are just for enrichment. Any questions right now? If there are any questions, I'll go through some enrichment slides. Here's some acute toxicities of radiation. How do you manage them? Oftentimes dermatitis is probably the biggest and most common toxicity we have with breast radiation, partial breast, whole breast. And oftentimes moisturizers like Aquaderm, Aquaphor, Meoderm, Aloe, Calendula, Biafine. We could go through a litany of different moisturizers. As long as they are truly moisturizing, seem to improve the rate of radiation dermatitis. For patients who have pruritic skin, hydrocortisone or mometasone are often very beneficial. Hydrocortisone over the counter, mometasone is a prescription medicine. For pain management, sensitivity in the skin, I found that mometasone actually helps quite a lot with that. But very rarely will you progress to requiring opiates or even Tylenol. Oftentimes it's just a slight sensitivity. If you have great sensitivity, really think about infection or a cellulitis as a possible cause, or even a abscess within the lumpectomy cavity. And finally, we have other medicines used for more advanced radiation dermatitis, Silvadene and antibiotics. You can also use a Zerodorm pad to provide friction protection, and Talfa pads as well. As for clothing, avoid an underwire bra. Much of the support is in the underwire, and it really cuts into the inframammary fold, which is doubly bad because that is an area of damp, possible Candida formation, as well as it is a location where the radiation oftentimes has a bolus effect for pendulous breasts. You can always avoid that by treating in a prone position. Here's some late toxicities, retraction and fibrosis in the left breast in this woman, as well as telangiectasias. These can be treated with post-laser therapy with your friendly local dermatologist. This can be treated with a reduction procedure with your plastic surgeon. Pneumonitis is an important side effect of radiation. It's managed with a very long taper of steroids, approximately 5 weeks to 6 weeks, and do a repeat CT to make sure it's gone away. Start at approximately 60 gray and taper 10 milligrams per week, 60, 50, 40, 30, 10, and off. Cardiac toxicities are a must, an important thing to note in this era. No woman should get any in this era with IMRT, with prone breast, with DIBH, no woman should ever get any cardiac toxicities. There are many different ways of sparing the heart, including active breathing, prone breast radiation, which is probably the best for most women who can tolerate this position. You get 0 dose to the breast or just scatter. Protons and APBI. And this is a very simple thing to do, prone breast radiation, as long as they can tolerate going onto their belly. Active DIBH, again, is a excellent way of sparing the heart. Prone breast and alternative beam arrangements are also excellent. If you have a woman who's very wide, you can just do 2 tangents, one here and one here, or you can do VMAT. VMAT plans don't get to the heart sparing that you might get with prone or DIBH, but you can still get a mean heart dose of less than 4, oftentimes less than 3. And other late toxicity include lymphedema, which is increased with axillary dissection as well as radiation of the axillary lymph nodes. And it's radiation-induced cancers, which again are very low, except in patients who are smokers. Please note that during your history and physical, and make sure you do not treat the lung. And the rate of soft tissue sarcomas and all other cancers are about 1 in 200 or 5 in 1,000, but 1 in 200 is the number I like to say. I think we've really run out of time. It's 6:03 now. So again, any other questions? There's several enrichment questions in the slide deck. I think this will be provided to you by the Osler Institute, and you can go over it in your own time. So
There
John,
was, there was one question that just came in.
yes,
It says, do you usually start TAM AI before concurrent or after radiation at your institution?
that's a really great question. Usually we do it after radiation, thinking that TAM will go on for years and years and years, and so what's a month or two of not taking it? But and also there's that theoretic improvement in tumor cell kill when you are not using a hormonal therapy, as the cells will cycle through theoretically more of the cell cycle when they're not deprived of estrogen or modulated of estrogen. But it's acceptable to do it during radiation too. It's not wrong. Oftentimes we find a very, very high risk patient who perhaps is a whisper away from metastasis, and you just feel too uncomfortable to stop the tamoxifen, or you just want to start it early. Any AI, that's fine. I would caution against using concurrent CDK4/6 inhibitors for the increase in risk of pneumonitis as well as other normal tissue toxicities, however, and certainly no chemo. There's a little controversy with the recent CREATE-X trial whether capecitabine should be started concurrently with radiation, especially for these women who are high risk systemically. And I've sometimes overlapped it at the very end of radiation, maybe a week or two, but usually not. Usually not. Usually we try to hypofractionate these women so that they can get onto systemic therapy as fast as possible. So that was the answer to your question, and also I tried to cover all of the other systemic therapy issues that might come up. Hope it was comprehensive. So John, it's 6:05. Is there a break, or should I just move on to the next presentation?
If you just want to move on, that's fine. Or if you want to take a couple minute break, it's up to you.
Sure, I'm ready to move on. I I also I also can take more questions. I'm not sure if the students want a break. Okay. Well, let's move on then, because there's a lot of material, and we should try and maximize our use of time.